we'll get started now. Shri. Yeah, Shri. Yeah, they're just getting it right. Welcome. I'm Devesh Kapoor, the director of CASI, and I'd like to welcome you all to our Nandanjeet Khemka annual lecture, which is our annual lecture of our center. We are very privileged to have as our speaker Dr. Srinath Reddy, who is the president of the Public Health Foundation of India. And I'd like to invite our co-chair of our board, Mr. Sanjeev Sopti, to welcome our speaker.
Thank you, Devesh. On behalf of CASI, it gives me great pleasure to welcome all of you this evening. First, a few words on CASI. I have been involved with CASI for over a decade and feel privileged to have witnessed its progression. Today, CASI is recognized as a highly respected, policy-oriented research center. Its presence at a premier educational institution gives it special vitality. CASI provides a vibrant forum for discussing issues that are determinant to the evolution of India. A great gratitude is owed to all who pioneered the founding of CASI and those who supported its development. The topic this evening: can India deliver on universal health coverage? Accessibility to healthcare is one of the defining and polarizing issues of our time. You can replace India in the title and pretty much drop in any other country, and a spirited discussion would ensue. In the context of India, no person is better qualified to speak on this topic than Dr. Reddy, and we are honored that he has agreed to share his insights with us today. Dr. Reddy is the president of the Public Health Foundation of India. He has also been a preeminent practicing doctor as a former head of cardiology at the revered All India Institute of Medical Sciences. He has more than 350 scientific publications to his credit, and his contributions to public health have been widely recognized through numerous awards and honors. Dr. Reddy is currently the president of the World Heart Federation and a member of the Leadership Council of the Sustainable Development Solutions Network, established under the auspices of the United Nations. He is the president of the Public Health Foundation of India, and I'm sure he will shed light on what that role entails today to us. Please join me in welcoming Dr. Reddy.
Good evening, ladies and gentlemen. It's indeed a privilege to be here as a guest of the University of Pennsylvania to deliver the CASI lecture, also associated with the name of Nandanjeet Khemka. The Khemka family have been benefactors of the Public Health Foundation of India, having initially contributed to the corpus for the establishment of the foundation. And Uday Khemka, as a member of the board, has been providing stellar leadership to our executive committee as well as our finance committee in particular. So it's particularly a privilege to be here delivering the Nandanjeet Khemka lecture. First, a disclaimer. The original topic that I had suggested for this lecture was, will India accomplish universal health coverage? Professor Devesh Kapoor, in his wisdom, altered the topic to read, can India deliver on universal health coverage? making it much more challenging with a clear note of skepticism. Under other circumstances, I would have probably reached back to those heady days of the end of 2008 and recalled that spirited slogan, "Yes, we can." However, landing as I have at a time when the federal government is shut down on the issue of Obamacare, I wonder whether the same slogan would find equal resonance now. Nevertheless, as has been mentioned in introductory remarks, any mention of universal health coverage attracts spirited debate, and India is no exception. I would like to, in this lecture, deal first with India's current public health status and some of the critical structural problems that exist in India's health system, and then talk about the concept of universal health coverage overall and as it pertains to India in terms of evolution of our policy towards adoption of a framework of universal health coverage and what actually it means in operational terms. Then I would like to discuss towards the conclusion the politics or the political economy of universal health coverage, and then look at the potential opportunities and the considerable barriers that we'll have to surmount if we have to really get to universal health coverage. Firstly, positioning the whole area of health and public health in particular in the context of development, it is very clear that India's health status lags behind its economic growth. Even though there is some despondency in recent years about India's economic growth slipping down from near double-digit figures to about 5% or so. Nevertheless, the fact remains that over the last 2 decades, India had achieved considerable progress in terms of its economic growth. Nevertheless, its health indicators have remained fairly poor. With 19% of the global population, India has 21% of the global disease burden. We have had some success. If you take 3 indicators of health, life expectancy, infant mortality rate, and maternal mortality ratio as important indicators, then in the area of life expectancy, we indeed have gained 30 years of life expectancy since our independence, from about 35 years to 65.4. So we must have done something good. Nevertheless, when you look at even how this life expectancy is distributed within India, you find that life expectancy in Madhya Pradesh is 56 years, whereas life expectancy in Kerala is 74 years. So there is quite an uneven distribution of this gain in life expectancy. And when we come to the even more sensitive indicators of infant mortality rate and child nutrition, which ought to be some of the most sensitive indicators of economic progress in a society. Because you may say that life expectancy and disease patterns in people who are 40 or 50 years old would have antedated the economic growth, but at least the children who have been born in the past 2 decades should have clearly evidenced benefit of that economic growth. Has it happened? In terms of infant mortality rate, we lose about 4,000 infants every day, equivalent to 12 full jumbo jets crashing every day. Our children die early, prematurely, and needlessly from very preventable causes like malnutrition, lack of immunization, diarrhea, pneumonia, and malaria. Let's compare ourselves with some of our neighbors as well as some of our peers in the BRIC countries. The infant mortality ratio in India is currently 47. Thailand, 11, Sri Lanka, 14, China, 16, Botswana, 36, Bangladesh, 38, Nepal, 41. The progress in Nepal and Bangladesh in the last decade, and particularly even over the last 2 decades, but particularly in the last decade, has been remarkable. And we have nothing to be proud of when we compare ourselves either with the BRIC countries or with our neighbors. These are going to be dismal facts that I'm going to be narrating to you, but I do so with the clear recognition that India's national bird is the peacock and not the ostrich. We can no longer ignore unpleasant facts. So in terms of child immunization, On providing basic immunization to our children, we are behind Bangladesh, Nepal, Thailand, Ghana, and Pakistan, to name a few. About 30% of Indian children go without DPT coverage, 50% without full immunization. And when you look at DPT immunization rates, Sri Lanka, even at the height of its civil conflict, had 99% coverage. Pakistan, where immunization personnel are being hunted down by terrorists, 88% coverage. Bangladesh, 95% coverage. Botswana, 96% coverage. India, 72% coverage. Undernutrition, with 43% of our children under 3 undernourished, the Prime Minister has called it a national shame. 25% of India's newborns start life with a low birth weight, and of those who survive the first year, 43% are underweight, and 66% are anemic by the age of 3. Brazil, 2%. Thailand, 7%. Nepal, 39%. And here we are talking of a demographic window of opportunity where, with the growth of our younger segment of the population, over the next 2 to 3 decades, we are expected to see accelerated economic growth. But if our children are undernourished to this extent, can we actually realize it? Particularly, not only in terms of survival, but also even those who survive suffering cognitive impairment. In terms of maternal mortality ratio, our maternal mortality rate is 4 times that of China and Brazil, and 6 times that of Sri Lanka, our immediate neighbor. In terms of infectious diseases, we have 1/3 of the world's tuberculosis cases. And apart from the fact that there are about 2 million new cases every year, drug-resistant tuberculosis is becoming a major threat. We have about 70% of India at the risk of malaria. In tuberculosis, our incidence of tuberculosis is 2 to 3 times more than that of China and Brazil. At the same time, even as we are grappling with some of these issues, which are considered the legacy of underdevelopment, we are also seeing the diseases of maladapted modernity racing ahead in the form of cardiovascular disease, diabetes, mental illness, road traffic accidents. India has about 61 million persons with diabetes now, likely to rise to 101 million by 2030. And if you are looking at cardiovascular disease, it's not only now the #1 killer in India, but because majority of the deaths occur below the age of 70, and indeed 40% of the deaths occur in the age group of 35 to 40. If you compare the age band of 35 to 40 and the deaths because of cardiovascular disease in that particular age group, India lost 9.2 million potentially productive years of life because of premature cardiovascular deaths in 2000, and it will lose about 18 million deaths, 18 million potentially productive years of life by 2030. For the same age band, this is about 570% more in year 2000 and 900% more than the United States of America. No country which aspires for accelerated economic growth and positions itself as a potential economic power of the 21st century can afford such a hemorrhaging of human resources in the productive prime of midlife. And when we look at a variety of other indicators, unfortunately, again, the same distress signals are seen. Unmet need for contraception, 21%. Full antenatal care with 4 visits, 37%. Skilled birth attendance, 52%. Children with diarrhea receiving oral rehydration therapy, 33%. Exclusive breastfeeding for 6 months, 46%. Of course, here there is a failure of the health system not only in terms of service delivery, but also in improving health-seeking behaviors and through improved health communication. But nevertheless, it's a failure of our public health system. And even beyond the health sector, when we look at the other determinants of health, which have a profound impact on health, like water and sanitation, about 50% of India does not have access to sanitation and clean water. In Bangladesh and Brazil, only 7% of the population defecate in the open. In China, only 4%. And in India, about 50%. There is also a poignant picture of health inequity. When you look at rural-urban comparisons, The doctor population ratio in urban areas is 1:750. In rural areas, it's 1:5,500. In some areas of Madhya Pradesh, it is 1:42,000. The rural population is 70%, but it has 25% of the dispensaries, 40% of the hospitals, and only 20% of the doctors. And even when you look at some of the problems that are there in rural areas and see whether primary health care could suffice to address them, 46,000 people die annually due to snake bite as they do not get timely treatment. About 110,000 people die annually as they do not get an ambulance service in case of an emergency. Clearly, our primary health care services, which were supposed to be the ones that were principally designed for rural health service, have not been serving their purpose. In fact, we have a very bare-bone primary health care service, principally addressing the issue of maternal deaths and averting maternal deaths, or providing safe deliveries. But even there, it's not been very successful. In terms of quality of care in primary care, a study by the London School of Hygiene and Tropical Medicine, published in the Economic and Political Weekly of May 2013, looked at 6 criteria for classifying the competence of primary care provision: 24-hour availability of services, clinical staff in position, training in the past 5 years. Have the health personnel received any training in the past 5 years? Is basic infrastructure available? Is equipment available? Are essential drugs available? Based on these 6 criteria, India's score was 52%. The low-performing states scored 48%, but even the high-performing states scored only 57%, and the Northeast scored 53%, which again goes to show that primary health care, which is absolutely pivotal for promoting health in a society and protecting it from leading to complications which require costly and technology-intensive secondary and tertiary care, has not been well provisioned. Clearly, there are weaknesses of the health system. Just to enumerate a few listed by Geeta Sen in another article in Economic and Political Weekly, there are low levels of public financing, inadequate focus on public health, either lack of regulation or weak regulation, no standard management guidelines, or if they exist, they're not enforced, shortfalls in infrastructure, especially rural, deficient human resources, deficient in numbers, deficient in skills, deficient in commitment, and maldistributed, poor use of data and poor performance monitoring, inadequate attention to quality in health services, poor personnel management, weak management of logistics and supply chains, overly centralized financial management, poor accountability to patients and communities. These are not necessarily only unique to India. A large number of other countries also have these ills. But when all of them are conflated together, then the health system becomes structurally very weak and functionally inadequate. And when you look at public financing, let's take up public financing. One of the major reasons for this problem has been public financing. India has among the lowest per capita public financing of health in the bottom 10 countries. Sri Lanka spends twice as much as we do in terms of public financing of health per capita. China spends 3 times as much. Thailand spends 4 times as much. We spend about 4.5% of our GDP on health overall, out of which only 1% comes from the government. That means 70% of our expenditure is private out-of-pocket expenditure. And that has a tremendous impoverishing effect on the people. And it has 60 million Indians sink into poverty each year because of unaffordable healthcare costs. 28% of rural residents and 20% of urban residents do not even seek healthcare because of the financial barriers. 40% of those hospitalized had to borrow money or sell assets for to pay for their care. Even in a well-developed state like Gujarat, Anirudh Krishna from Duke University has published a study ranging from 2001 to 2010, where 88% of those who fell into poverty, said that was because of unaffordable healthcare costs. So it has a tremendous impoverishing effect in terms of health. And anybody who talks about development or sustainable development or inclusive development, or talks about poverty reduction as a goal of the sustainable development process, will have to recognize that unless impoverishing effect of healthcare is attended to, poverty reduction will remain a mirage. Now, coming to the human resources for health, in terms of doctors, the doctor to population ratio is 0.5 per thousand overall. The global norm is about 1 per thousand. China is 1.6 per thousand. We require, if we follow the current doctor-dependent model of healthcare, we require about 400,000 doctors more by 2020. But we also have 700,000 doctors trained in traditional Indian systems of medicine, Ayush. They are not appropriately utilized in the Indian healthcare system. So there is an opportunity to actually dovetail them into the main system. But nevertheless, we cannot be entirely dependent upon a doctor-dependent system, for the simple reason that even if we produce more doctors, firstly, there is no guarantee that they'll go to rural areas. The urban aggregation will continue, or external migration will continue in a highly mobile labor market. Secondly, those who are trained in urban tertiary care centers with very little feel or aptitude or competence for serving in rural areas. Therefore, a young, fresh doctor being thrown into the rural areas is totally being thrown into the deep end without adequate preparation. Nurses, we are even worse off. Our nurse to doctor ratio is 1.5:1. The desirable ratio is 3:1. Brazil has 3:1. South Africa is 5:1. We require 16.2 lakhs more by 2020 for nurses. Allied health workers, a variety of allied health workers like optometrists, lab technicians, mental health counselors, physiotherapists, rehabilitation personnel, and so on, dental assistants, and so on. If you take all of them, we need 6.4 million more of allied health professionals by even now to fill our gaps. And of course, as our healthcare system grows, the gap will be much more. But this is not only a crisis point, but this is also an opportunity. I'll revert back to that later on. Why I believe that these shortages sometimes provide an opportunity. Firstly, if we look at the opportunities for dealing with this, and we have to deal with this very clearly, the root cause response calls for strengthening of health systems through capacity building in health. And to some extent, the government has provided it over the last 9 years through the National Rural Health Mission launched in 2005 and through the Rashtriya Swasthya Bima Yojana, which was launched 2 years later. Now, the National Rural Health Mission was supposed to be an integrative platform providing rural health care, but it focused mainly on maternal and child health. It had some positive features. It had positive features of considerable decentralization. It created a whole cadre of social mobilizers, the ASHAs, the accredited social health activists at the village level, were supposed to be motivating people for institutional deliveries and for child immunization. It also had other features like setting up Indian public health standards and some degree of monitoring, a common review mission for evaluation, and so on. Some good features came in, and a certain degree of financial independence and autonomy to the states for planning. But it failed to provide the integration between various vertical programs that were fragmenting the system and continue to fragment the system. The multiple vertical programs which had their own independent lines of hierarchy could not really be dovetailed together into an efficient platform. Equally importantly, they focused only on maternal and child health. All other diseases were left to other vertical programs, and really there was no service for key elements of health needs. There was also a shortage of human resources. The ASHA may motivate a pregnant woman through cash incentives, conditional cash transfers which were introduced as a novel feature of the scheme for the first time, may motivate a pregnant woman to seek an institutional delivery. But at the level of that institution, if there are no trained anesthetists, if there are no obstetricians, if there are very few doctors trained to handle a complicated delivery, you're merely transferring the death from the home to the death to the institution. So the impact on maternal mortality and neonatal mortality is yet to be demonstrated. There is no demonstrated impact yet on out-of-pocket expenditure. If we are to reduce out-of-pocket expenditure, then how are we going to do it? There is no element of continuum of care. So the key elements of what ought to have been a functioning, well-integrated health system are still absent in the NRHM. The Rashtriya Swasthya Bima Yojana is the first social security scheme, considerably inspired by the German model and funded indeed by the GIZ and also by the World Bank initially. It is India's first social security scheme, and indeed it is the world's largest now health insurance scheme. It was meant originally to cover people in the unorganized sector. And the coverage was about $600. Currently it will be $500 with the rupee falling for a family of 5. There was mandatory enrollment and considerable use of IT for recruitment as well as follow-up. Over the recent years, fraud detection mechanisms have been strengthened. So it has provided a platform now for providing some level of social insurance. But does it suffice? Firstly, it focuses only on secondary care provision. It focuses only on hospital networks, public and private. It does not have anything to do with primary care. It does not have any pattern of integrated care or continuum of care. It focuses only on in-hospital care. When we say 70% out-of-pocket expenditure in India, 70% of that is due to outpatient expenditure, not due to hospitalized expenditure. 72% of out-of-pocket expenditure is due to medicines. And the RSBY only provides for hospitalized care, does not provide for outpatient care, does not provide for continued medication, therefore has no impact whatsoever on reducing out-of-pocket expenditure. In fact, a study done by my colleagues in Public Health Foundation of India showed that where some of these insurance schemes were operating, whether it is the RSBY or the Arogyashri scheme, which focuses on tertiary care in Andhra Pradesh, the actual out-of-pocket expenditure went up because private hospitals may be absorbing the 30,000 rupees, but they also add on costs. The post-discharge costs are not accounted for. So while some lives have been saved, some diseases have been attended to, as far as financial protection is concerned, it has served no purpose. Is it financially sustainable? If the claims ratios increase, it's not sustainable. So far, the scheme has been working in states like Jharkhand and Bihar because of very low registration rates and very low claims ratios. But in Kerala, where the claims ratios have actually gone up well beyond 120, 160%, the insurance companies are threatening to walk out because they're asking for increased premiums each year. And when we asked them, during one of their depositions before our committee on universal health coverage, as to why they are doing so, they said, oh, in Kerala there's a particular problem because people are very much educated and they look at healthcare as a right and they demand services. God forbid if rest of India gets educated. So, is it financially sustainable? Unlikely. Secondly, the re-registration, the re-enrollment rates are falling now because people are also not seeing enough service being provided to them. So we're going to see a major problem in terms of RSBY as the platform. But okay, I've given you the dismal picture so far. But we need to really ensure that we overcome this despondency and plan for a much better future. Because as Toni Morrison says in the Song of Solomon, if we do not create the future, the present extends itself. And the present is untenable, so we have to create the future. And how do we do that? The solution would be adoption of universal health care paradigm to address health system needs, and skill building and youth employment generation to allied health reform, and affordable technology solutions for increased access. And I'll deal with each of these briefly. Why universal health coverage? It's not a new concept. It started with Bismarck in the 19th century, was subsequently elucidated by the Beveridge Report in the UK, which led to the formation of the NHS. And then, of course, many countries have subsequently debated UHC in a variety of models, and many low and middle income countries are adopting it. According to Margaret Chan, the Director General of WHO, universal health coverage is the single most powerful concept that public health has to offer. Okay, she is a public health professional, she is bound to say that. But let's listen to Jim Kim, President of the World Bank. We must be the generation that delivers universal health coverage. This is what he said at the World Health Assembly in May this year. And the United Nations, in December 2012, in a debate on foreign policy and health, encouraged member states to plan or pursue transition of their health systems towards UHC, and recognize UHC as an important element in the international development agenda. And it's very likely that in 2015, when the new Sustainable Development Goals are enunciated, universal health coverage will be the health goal or an important component of whatever health goal is chosen. So there is a tremendous amount of global interest in universal health coverage, and that is because it is seen as integral to development, because without health, societies cannot develop or sustain development. It is also an inalienable human right. Everybody recognizes it as an important human right as well. So whether you're taking it from the discourse of economic development or taking a rights perspective, it is very much center stage. But what do we mean by universal health coverage? When I was at a meeting of the Sustainable Development Solutions Network in New York last month, there was a very interesting debate that took place between the Americans and the non-Americans. Americans said it should be access, not coverage, because they saw coverage as only how many people are covered by insurance. They said access is the more important thing. Access means that people not only are able to afford, but are getting good care. Everybody else, the Europeans, the Indians, and everybody else is exactly the other way around. Access means that you have geographic access, or some access is provided. Somebody said you can walk into Dorchester Hotel, or access is there, but can you afford to stay there? So those are issues that are there. So there are obviously differences in what we mean. And I was reminded of Lewis Carroll in Through the Looking Glass. Quote, "When I use a word, Humpty Dumpty said, in a rather scornful tone, it means just what I choose it to mean, neither more nor less. The question is," said Alice, "whether you can make words mean so many different things." So obviously, the universal health coverage has different meanings. So it's important for us to define exactly what we mean by universal health coverage. So universal health coverage, in a simple definition by the World Health Organization, is when all people receive the quality health services they need without suffering financial hardship. Emphasis on all, emphasis on quality health services, and emphasis on avoiding financial hardship. So there are three dimensions now. First is, if you take a magic cube, then one plane is of population. Who is covered? Second is services. Which services are being provided? Third is financial protection. What do people have to pay out of pocket? Now, each of these dimensions is very important. You cannot function only in one plane. But you may not be able to fill the whole cube on day one. You may have to say, okay, we'll cover all the population with primary healthcare services and then gradually build up. You may say, okay, we'll reduce the amount of out-of-pocket expenditure and co-payments to this extent, and as resources increase, we can increase the coverage of people, number of people covered, or increase the depth of services provided, or reduce the amount of out-of-pocket expenditure, depending upon the priorities and the context in which the country is located. But at some point in time in the future, we would like to see most of the cube covered. And that is an area where each country will exercise its options. Population, who is covered? That's of interest to politicians. They would like to see as many beneficiaries as possible. Services, which services are provided? That's of interest to health professionals. I would like to provide the best service to my patient. So I want everything best in the world. I'd like to provide every single service. Financial protection, that's of interest to economists and policymakers managing the health system. But for the people, all three matter. So we have to address all of these three dimensions, but not be under the illusion that every country can achieve 100% of this on day one. We have to accept that we have to move in that direction, and the trade-offs between which plane you cover more is entirely dependent upon the country preferences. But at least basic primary care services must be provided to everybody free of cost. Now, the financing models are several, mainly tax-funded, that is UK, Thailand, and Spain, mainly mandatory private insurance, United States, at least that's the plan under Obamacare. Mixed models where tax resources are coupled with mandated contributions from formal employment sector, the employees in the organized sector, Austria, Belgium, Germany, Israel, Japan, South Korea, these are some of the examples. India too has some example of organized sector, what's called the employee state insurance scheme and so on. So now you have a combination of different sources of funding in terms of health financing for universal health care. We cannot claim that one is definitely better than the other. But clearly, in a country like India, where 93% of the people are in the unorganized sector, to expect payroll contributions to be the source of social insurance is unrealistic. So you have to think of other methods, and principally it has to be tax funded, especially when the level of public financing is so abysmally low as 1%. But again, we are not really saying that one model is definitely better than the other. It may depend on the country context. As long as the objectives are the same, it's fine. Again, as the Lebanese poet philosopher Khalil Gibran said, say not I found the truth, but rather I found a truth. So there are several truths, but we'll have to try and discover each one for ourselves in our own context. But then that brought us to our own quest for truth, the high-level expert group in India. The Planning Commission of India in October 2010 established a high-level expert group on universal health coverage. I was asked to chair it with 14 distinguished colleagues from different sectors. And we were asked to prepare a framework for universal health coverage. We were considered to be an independent group, not linked to the government. The independence was supposedly so that we could offer free and unfettered opinion. But the subtext was that we can reject your report because you're not a government body. So fine. So they retained that option as well. So we came up with our own definition of universal health coverage, saying, of course, that a range of services will have to be provided: preventive, promotive, curative, and rehabilitative services. And we said all citizens should be entitled to it. And the government should be the guarantor and the enabler, even though it may not be the sole provider. So at least it has to put in framework and take responsibility for delivery through a combination of actors like public sector, private sector, voluntary sector. The key recommendations of our report were to adopt universal health coverage as a national commitment to be initiated in 2012 and to be fulfilled by 2022, to commit 2.5% of the GDP from 1% as public financing of our health in the 12th plan period between 2012 and 2017, to conduct a review of government-funded insurance schemes which were actually profligate, because politicians like to put in these schemes like Arogyasri and others because it was helping poor people to get tertiary care. But that was a very limited approach to the entire problem of health services, because primary health care was not being attended to, outpatient care was not being attended to, and on the other hand, it was emptying the health budget into costly tertiary care. Andhra Pradesh was spending 55% of its budget on the Arogyasri scheme provided tertiary care. So we said all of these must be reviewed and integrated into the UHC framework, not disconnected. The fragmentation should be avoided. Primary and secondary and tertiary care must be well knit in a continuum of care, something which has been called accountability care here. We said prioritize primary health care for financing. 70% of the increased finances must go to primary health care because that is fundamental for meeting the needs of the most people, particularly of the poor. And secondly, by acting as a gatekeeper, it will prevent unnecessary referrals to secondary and tertiary care. Therefore, it will cut down healthcare costs because it's also the responsibility of the government, any responsible government, to contain healthcare costs. You cannot have healthcare costs mounting to 15, 16, 17, 20% of the GDP. So, to facilitate the future Ministry of Health agendas, also take a social determinants approach by framing policies in other sectors which are sensitive and responsive to health concerns. Provide essential drugs free of cost, to establish credible and effective regulatory systems, and enable community participation by institutionalizing health councils and health assemblies with government support. Now, the question is, you may say this is utopian. Is it financially feasible? Is there fiscal space, particularly in a contracting fiscal space? We had Nachiket Moore on our committee from ICICI Insurance, ICICI Foundation, now member of the Reserve Bank of India Board of Governors. So nobody can fault him for being a bleeding liberal asking for profligacy of government spending on unaffordable causes. Nachiket's analysis is that now the health spend in India is $150 purchasing power parity adjusted per capita, out of which $40 is coming from out of pocket, from government spending, and rest is out of pocket. The estimation was if you calculate essential services, which means all of primary, virtually all of secondary, and some of tertiary, then you can provide all of that at $100 to $125. So we are not actually going to be increasing our health expenditure, except that by increasing public financing, you're shifting the balance between government spending and private out-of-pocket spending. So he said so total national expenditure at 4.1% of GDP exceeds the amount needed for UHC. This is a conclusion from Nachiket Moore and Govinda Rao, again, a fiscal hawk. 8 states already have adequate resources for UHC with no additional resource allocations to achieve UHC by 2022. Of course, it has to be not on a fee-for-service basis. It has to be on a capitation basis, integrating primary, secondary, and tertiary care, with some flexibility at the edges to provide additional incentives to influence health-seeking behavior and take care of very expensive diseases that may not be evenly distributed in the population. So the conclusion was India should offer UHC, she can easily afford it. Government needs to perform the pooling function and increase public expenditures from 1.2% or 1.1% to 3% of GDP by 2022, and general taxation combined with social health insurance to be used to generate the necessary resources for universal access or universal coverage in this case. We also went on to say no user fee should be levied at any level. It should all be prepaid. No, it should all be cashless. This again sounded heresy to policymakers who are substantially influenced by the IMF and the World Bank recommendations of the late 1980s, which became the economic gospel of healthcare restructuring in 1990s. But then, it is not only Jeff Sachs who says that user fee is inequitable. It is not only Margaret Chan who says it shuts the door on the poor. President of the World Bank, Jim Kim, in World Health Assembly this year said it is unjust and inefficient. So the World Bank has said a mea culpa now and said user fee should not be levied. 70% of healthcare expenditure to be reserved for primary care, and national health entitlement cards to be issued, possibly even linked to Aadhaar, the new national identity card. But we have to start somewhere. Primary care, yes. But essential medicines, since 72% of the out-of-pocket expenditure is because of medicines, can we provide the medicines in the essential list of, national list of essential medicines free of cost, at least at public facilities? And if so, how much would it cost? 0.1% of GDP. That's all. And if we do that, we can give medicines free of cost, essential drugs, at all public facilities, and make a substantial dent in out-of-pocket expenditure. And there are models that are validated. Tamil Nadu Medical Systems Corporation has been doing it for 2 decades with an excellent system of pooled procurement. They have driven the price of medicines down through the monopsonic power of pooled procurement and purchase to 30% of the prices. Quality assured drugs being distributed without stockouts, warehouses in every district. Now, those models have now been adopted by some other states, but this is eminently doable. The big question came about, okay, you're going to purchase the services, who is going to provide the services? Is there going to be a purchaser-provider split, as they call it? So is the government only going to be the purchaser, or is it going to be a substantial provider, or the only provider? So here, the feeling was that the government must retain some control, at least up to the state level. But at the district level, the district health system manager can decide what are the resources available in the public sector, strengthen the public sector, but co-opt and contract the private sector as per need and availability. So the purchaser-provider split actually operates at that level rather than at the state level. But others who have different models, we can certainly consider them. But the idea here was that the state cannot totally disengage from that function of some provision as well. But all of this, whether public or private or a combination of both, requires strong management and regulatory reform, which was also recommended. In terms of ensuring essential access to, universal access to medicines, we recommended spending on drugs at 15% of overall public expenditure, and also a system akin to the Tamil Nadu Medical Systems Corporation. What about human resources? You may give more funds, you may give drugs, but if there are no people to deliver the services in the health sector, then what are you going to do with them? Here comes the question of non-physician healthcare providers, of rejecting the time-honored, doctor-dependent model of healthcare delivery for primary healthcare. You certainly require doctors for secondary healthcare. You certainly require doctors for tertiary healthcare. But many of the primary healthcare functions in rural as well as in urban areas can be performed and are being performed globally by well-trained, non-physician healthcare providers like nurse practitioners, mid-level health workers, what are called health extension workers, or physician assistants, and so on, and by community health workers. The whole idea of task shifting from specialist physicians to non-specialist physicians, from them to nurses, and from them to community health workers is reasonably well established in HIV/AIDS and a number of other cases, and it's been functioning very well. Task sharing as well, multi-skilling people in different programs for performing functions not only of their program but some other program. It is ridiculous that a malaria technician, lab technician will not see a tuberculosis slide. There is no reason why a tuberculosis health worker cannot also combine elements of tobacco control program in their functioning. So we need to economize on our utilization of health personnel, but utilize them also much better by giving them greater role and responsibility. And this has been validated. Our colleagues did a study in Chhattisgarh where they compared the performance in primary care, particularly for issues like malaria, tuberculosis, and others, comparing allopathic doctors with the 3-year trained, what are called mid-level health workers, what are called rural medical assistants, that's the nomenclature used then. Now they're being called community health officers, and the Ayush, the traditional systems of medicine, and some others. They showed that these 3-year trainees, the so-called rural medical assistants, performed equally well, and in some cases better, in malaria detection and treatment even better than the 5-year allopathic doctors. So the validation is also there that they can actually do their job. that it's not a cop-out that we are going to them, but it's actually something that really works. And now with technology, with point-of-care diagnostics, with IT systems, with uploading of data, linking to telemedicine, multiple methods in which technology can be brought to the front lines, and our frontline health workers can be empowered with the power of technology to deliver many of these services. We don't have to still depend upon a very reluctant doctor to go to the rural areas. We can actually deliver good primary health care even in the absence of a doctor. Of course, if we can position doctors, retain them, nothing like it. But we don't have to depend for everything on the doctors, and we can utilize our doctors much better. So what is the role of the government and what's the role of the private sector? Since there are large health shocks that need to be provided, government needs to ensure pooling. Because there is poor health-seeking behavior and information asymmetry, government needs to ensure compliance and improved awareness, including insurance education, where insurance is being used. Since health expenditure is usually of a non-postponable character, government needs to ensure prepayment. So cashless services, preferably through a single payer. The private sector is an important player. It serves anywhere between 60 to 70% of all our health services in the country are provided by the private sector, which is multi-layered. On one hand, you have the corporate hospitals. On the other hand, you have the unqualified medical practitioner masquerading as a doctor in the rural areas and the urban slums. And in between, there are very many others as well, including the individual private practitioner, the small nursing home, and so on. How do we integrate all of them into this particular framework of universal health coverage? Because it's unthinkable that you can manage without the private sector. How can you think of controlling drug-resistant tuberculosis if you don't deal with the private practitioner who's prescribing TB drugs in an improper manner, if standard management guidelines do not apply to them? So you have to bring them in, but in a responsible manner. But the private sector says that it is interested in tertiary care. Now it is getting interested in secondary care. There are a large number of hospitals focusing on maternal deliveries or relatively low cost but fairly high quality surgical procedures and so on. But will they ever enter primary care? And if they don't enter primary care, how do you build a continuum of care between primary, secondary, and tertiary? The kind of accountability care that US has been also proposing. So these are some of the challenges that remain. But we do need to bring them in by contracting them in, but by having a very clear-cut mechanism by which the deliverables are clearly defined and accountability is also ensured for both the partners, both the public and private sector. What we are suggesting is network of both public and private institutions stretching from primary to secondary and tertiary care, which will function as one unit with a continuum of care, drawing on public financing and social insurance, but delivering the same set of services. The private sector, of course, can give higher cost care to those who opt out of the system. If a very rich man wants to go to a private doctor and pay from pocket, welcome. But everybody should be entitled to at least to the basic services if they want it. And that's what we are really saying at this point in time. Public-private partnerships have come under some disrepute in India. Many of the cynics say that PPP should be defined as partnership for private profit. I would rather say it should be defined as partnership with a public purpose. Define the public purpose, define the deliverables, and define the accountability. Therefore, there are governance challenges, but we will have to overcome them through strong regulatory systems, which we have also recommended. We have recommended standard management guidelines. We have recommended also a NICE-like institution which exists in the UK, where you have a clear-cut idea of what are the appropriate medical practices, cost effectiveness, which I believe in the US has attracted considerable criticism as death panels. There are no death panels in the UK. NICE functions very well, I can assure you. So we are thinking of setting up a NICE-like institution in India to look at standard management practices and standard management guidelines. Of course, the Swedish Nobel laureate economist Gunnar Myrdal said, health leaps out of science and draws nourishment from the totality of society. We can't only focus on health sector. We have to think of water, sanitation, nutrition, environment, multiple areas in other sectors, urban design, transport, agriculture, food processing. All of them will have to be brought into the framework becoming more sensitive to health. But water and sanitation particularly are absolutely critical needs. Finally, to conclude, the politics of universal health coverage. Will it succeed in India? Firstly, India has now taken a rights-based approach, right to information, right to education, right to food. Many people may say that is it giving entitlements which it cannot deliver. But on the other hand, it is likely that right to health may be the next one to follow. The National Advisory Council, chaired by Mrs. Sonia Gandhi, has already approved. Our recommendations have been mostly reflected in the 12th five-year plan with some modifications. But many of our recommendations have now been adopted also by the National Advisory Council, which has recommended to the government. I do not have great hope that it's going to happen before the elections. But what will happen after the elections? Will both the parties, irrespective of which party comes to power, be wedded to this? One would expect, possibly, since the National Advisory Council has spoken, if the same government comes back in some other form, it may follow up. But what happens if it does not? Last week brought great hope in that direction as well. There is a youth group of students loosely affiliated but not clearly identified with Mr. Modi, which conducted a national essay writing competition on 20 different development themes. I was asked to judge, by invitation of the students, to judge the health topic. The topic was universalizing primary health care. And I can tell you that the entries were remarkable. They did not come from medical colleges. They came from institutes of management, business schools, and so on. IITs, they were remarkable. And the depth of understanding and the passion was remarkable. Secondly, 2 days later, I got a call from somebody who is writing BJP's election manifesto, a vision for 2025, saying that we've read your report, we've read your articles, we're very much interested. So can you answer some of these questions? Because we may want to put universal health coverage very prominently in our vision for 2025. So I was surprised. Irrespective of the election, if major political parties take this up as one of their causes, we'll be delighted to do so. But states are already moving ahead. 2 days ago, Karnataka announced that it's going to be modeling universal health coverage in the districts of Mysore and Raichur. And they said they will be following the recommendations of the high-level panel established by the Planning Commission. They've invited the Public Health Foundation of India to join as their technical partner. This morning, the Health Secretary of Karnataka was on the phone while I was in New York. And I told him I'm going to be giving a talk this evening, and I'll mention this is what you're saying. Kerala has again invited us to provide technical assistance. There are other states now looking at universal health coverage. Essential drugs. Rajasthan has already done it after Tamil Nadu since last 2 years. And it's remarkable. Their per capita expenditure on drugs through public purchase has gone up. The private expenditure on drugs has gone down. Impoverishment due to drugs has gone down. It's been very clearly documented. More importantly, inpatient and outpatient attendance at public facilities, especially primary healthcare centers, has zoomed up. Confidence in the public system has been restored just by giving essential drugs free of cost. So things are happening now. In terms of drugs, Tamil Nadu, Rajasthan, Kerala, Madhya Pradesh, Orissa, they've already established the essential free drug supply. Pilots are being conducted for universal health coverage in Karnataka, Kerala, and Orissa. So we are moving ahead indeed. So finally, to wrap up, if you're really looking at why we want universal health coverage, of course, greater equity, financial protection, improved health outcomes, efficient, accountable, and transparent health system. 3 chief medical officers of Uttar Pradesh involved with NRHM drug procurement died violent deaths, 2 murdered and 1 suspicious suicide in jail. And if we cannot afford to have chief medical officers having lower life expectancy than the average Indian male. So reduce poverty, greater productivity, but increase jobs. I said I'll come back to this. If 6.4 million jobs are to be created for allied health professionals and many more for community health workers and nurses, India's demographic window of opportunity, which could be otherwise wasted, can actually result in job creation. You're going to see a large number of young people wanting to enter the labor market, because that is the expanding segment now, 15 to 59 years. If they don't have jobs, particularly when jobs are going to be less in a situation where both agriculture and industry are getting increasingly mechanized, the jobs are going to be less in those sectors. If we don't provide them jobs, there's going to be social unrest. On the other hand, India can provide the health workforce not only for itself, but for the rest of the world, where people are aging, and they will not have the ability to expand their health workforce. So we can actually train these people, not only as doctors and nurses, but in a variety of allied health professionals, saturate our health system, and export them to other countries if required. And that is going to be a new boost for our economy, because job creation is going to revive a sagging economy. And that is going to be absolutely important for us. We exported plumbers to the Gulf in the 80s. We have exported IT technicians in the 90s. Now is the time we are going to export our health workforce, of course, after serving our own needs. So there is no reason why it should not happen. So I will end, Professor Kapoor, by saying, yes, India can deliver on universal health coverage. It's not going to be an easy task, but nothing is easy. So coming back to Obama, with whom I started, President Obama, and yes, we can. I would like to remind him, as well as ourselves, of another great American, Martin Luther King, who said, "Change does not roll in on the wheels of inevitability. It calls for continuous struggle." Universal health coverage is not going to be easy, but it will happen. Thank you.
Thank you so much.
Thank you, Dr. Reddy, for that enlightening speech. First of all, I would like to know a little bit about Public Health Foundation, because there's nothing about Public Health Foundation here. The purpose behind the question is that to see if some of the people who are based here can start a movement to support you if you're interested in implementing universal health coverage in India, because I couldn't get much of information on Universal Health Foundation. In your speech, you touch upon diabetes of 60 to 61 million people. That's a subject I'll set aside, because it's a global problem as opposed to the Indian problem. Because the incidence of diabetes among the Indians as a race is about 5%, where the world average is only 0.5%. There are worldwide institutions like Mayo Clinic who have been doing research on that problem, trying to find out an answer for that. They're not being able to find it. So I think that should not be taken as India problem. The third is universal health coverage. In India, we have a tendency to reinvent the wheel for everything. Universal health coverage exists in different forms in different countries. You can have the Canadian model, you can have the Australian model, you can have the UK model, you can have the European model, you can have the Obamacare, which you briefly touched on, the US model. It depends upon what is more appropriate for India and how do you implement it. And one thing I would suggest is that may God help you if the central government is going to take the initiative. Because it's going to be a total failure, because any initiative taken by the government has not been that of a success in the country. Yes. And if you look at the geopolitical situation, in the 6 states you alluded to in your statement, like Bihar, Orissa, Rajasthan, Madhya Pradesh, Kerala, if you look at the growth of those countries, they have been much above the average of the India, 8%, 10%, etc. I think the authority for universal health coverage has gradually to devolve on India. And you said technology as a challenge. That I find it very difficult to believe, because the technology for healthcare services provided in the US for most of the hospitals, interacting between the providers, hospitals, and the insurance is provided by Indian companies. And I can tell you, for example, the most important company is Apollo Health Street from Chennai. You know that. They've got about 800 people in New Jersey handling the technology for the healthcare. So that's not a problem at all in India. See, the question of willpower, how you do it, how you implement it, and the most important challenge being, are you able to tackle the corruption in the country?
We'll take a few.
Yeah. Okay.
Yes.
Thank you for that, Dr. Reddy. I was very curious. Twice in your talk, you mentioned Ayush doctors and the 700,000 workforce that exists, which you seem to hint could address the issue of the shortfall of personnel. Can you say a little bit about their skill set and whether their knowledge of traditional medicine is an impediment or something that you in the Public Health Foundation have seen to be an asset for creating the kind of workforce that you need? Because the second time you talked about them, you said their performance as community health workers was excellent and therefore not a cause for concern. So is it their knowledge of traditional medicine actually useful or something that they need to retrain in biomedicine? Thank you.
Shall I take this too? Okay. Because there have been a series of questions, I thought I'll take this series first and then go ahead. As far as the Public Health Foundation of India is concerned, it started as a public-private initiative with 1/3 contribution from the Government of India, 1/3 from the Gates Foundation, and 1/3 from private philanthropy. The purpose was to set up schools with multidisciplinary training in public health, because such schools did not exist in India before, other than a small school in Kerala, which is producing very few public health professionals. In general, public health within courts was being taught only in medical colleges where doctors were teaching doctors. The broad multidisciplinarity of public health was not available, nor was there health system connectivity. So in order to redress that, this whole initiative was there. But we realized it's not just teaching and research. You're required to work with health systems and alongside and try and strengthen them. We also need to create affordable healthcare technologies for primary healthcare. So we have now a very strong, almost a 800 strong force now, and out of which about 650 are public health professionals of various categories, not only doctors, nurses, nutritionists, and so on, but anthropologists, social scientists, management experts, engineers, epidemiologists, biostatisticians, all of them working together to teach, train, and do research, and to also to create transformational interventions. We have 4 functioning institutes now in Delhi, Gandhinagar, Hyderabad, and Bhubaneswar, a 5th one coming up in Shillong. 2 other ancillary centers functioning in state government provided facilities in Bangalore and in Gwalior. But our reach in terms of our research, training, as well as health system engagement is across the country. And we have partnership with more than 80 international academic institutions, including some of the top-line universities here and in the UK. And we believe that through our own contribution, we are able to also influence government policy by active engagement in policy formulation. And even when we don't have a seat at the table, we try and influence policy through advocacy. But we provide technical support to the government as the official technical partner for the National AIDS Control Program. And now, after the disastrous performance in routine immunization, last year we were invited also to be the technical support unit for routine immunization. We have developed the blueprint for allied health professionals for India for training institutions. So in a sense, we engage very closely with the government, both at the central and state level. Diabetes is not a unique Indian problem, certainly not. But the problem is of the very early onset of diabetes, which often springs up in India, and at relatively low body mass index. Obesity is often seen to be associated with higher body weight, but in India, even thin diabetics are not at all infrequent, and with central obesity or waist circumference being a problem. But there are certain features that are there in India which are a cause for alarm. And therefore, and the sheer numbers are overwhelming. But I'm not comparing with Nauru or Pacific Islands where diabetes is very high. But the fact that even at a lower threshold of body mass index, we are developing glucose intolerance and metabolic syndrome is a cause for concern. But certainly I agree with you that we should not describe it as something totally distinctive and unique. It should be seen as a general developmental problem as well. UHC models, I completely agree with you. I mean, there's no discord. I said there are different models for different countries and we'll have to choose our own model depending upon what is most appropriate for our context. That's why I said there is no single truth. There are multiple truths. But fundamentally, there has to be commitment to primary healthcare services. That's the minimum non-negotiable element. As far as the central government is concerned, I agree with you that states have a much greater role, even constitutionally and otherwise in India, to deliver health services. We have to deal with the states very clearly, and we have to get the universal health coverage rolled out. But remember, central allocations are also important. Because if states like Bihar are doing well recently, but if they have a fiscal constraint, Kerala spends 3 times more per capita in terms of public financing than the state of Bihar. So, and Bihar has greater health needs. So unless there is preferential allocation to Bihar in the central plan allocation for health, then Bihar is never going to be able to catch up. So you do need the center and state to work in tandem with universal health coverage as the objective. You can't say that totally dismiss the center. It's not going to happen. Then in terms of devolution, I certainly agree that much of this function has to be devolved. I never said technology was a challenge. I said technology is an opportunity. I said technology is an opportunity for empowering frontline workers to perform many more functions than they were previously considered capable of. And we ought to utilize the technology to our advantage. And India is capable of not only innovating in health system interventions and innovations, but also in the utilization of technologies. We can be the innovation crucible and demonstrate how technologies can be effectively utilized for this purpose. Willpower and corruption, well, that's a universal problem. I mean, that's not a unique Indian problem.
It is not. It's a
Oh.
problem we know, but rampant in India.
Okay.
We said cancer in India. For Christ's sake, excuse me.
Sir,
It's a universal problem. India is the only country which doesn't attack that problem.
well, I do not know. I cannot really...
I mean, there are corruption here also. I'm not saying that. But these people are being both. I mean, look at for example. Take SSC Capital.
Sir,
Somebody is being paid like for $2 billion. Tell me one example in India.
Well, we could also argue that Mr. Lalu Prasad Yadav, Mr. Kalmadi and all of these people are in jail. But we could also argue, and we can also argue that in China people are being hung alternate day, but still corruption has not gone down in China. So let's not get into comparisons that way. We are not denying that India has a major problem of governance deficit or that corruption is an important challenge to be tackled. But I think dismissing India as the most corrupt country and most incompetent country in dealing with corruption, I think is an exaggeration which I will not accept. And coming to... Pardon? It affects healthcare. It affects healthcare because there are a lot of leakages, for example. I mean, the money that is allocated for the National Rural Health Mission, depending on the states, a lot of drug procurement, a lot of other losses are there. Corruption at other levels also. Transfer of doctors, transfer of nurses. At every level, corruption corrodes the system. But while we are quite conscious of that fact, and we need to take remedial measures, we cannot say that this is a factor that has not been recognized. There is a resistance coming up, and the resistance will come much more effectively if there's a community monitoring system put in place. There are health assemblies, there are health councils like in Brazil and Thailand, which have effectively stemmed the health system corruption, brought in greater accountability. We have asked for that. So the greater the decentralization, the greater the engagement of the local actors at the community level, the greater the watchdog function, then the local level corruption at least will be stemmed substantially. So we need to bring in some of these elements into play. Certainly, I do not deny the fact that this is a challenge to be met. But I will not react to it with despondency. I believe it's important for all of us, globally and in the country, to ensure greater transparency and accountability. And universal health coverage, if properly framed, with proper regulatory mechanisms, proper monitoring systems, proper levels of community empowerment, can actually bring in the transparency and accountability. Coming to Ayush doctors, actually, they didn't do very well in the Chhattisgarh experiment. It was the 3-year trainees who did well. But they have had 5 years of training in their own disciplines, where much of it is common to allopathic training. A lot of basic sciences training is common. A lot of pharmacology may differ, but a lot of other therapeutics are common. So many states are now considering a bridge training. Maharashtra has introduced a bridge training in which they are given some additional allopathic component and then are asked to serve in primary healthcare centers. So that's an opportunity that needs to be looked at. But why force them only to be allopathic doctors? give them their own drug supply, let them play their own role. So there is no reason why they should be sort of pretend allopathic doctors only. But they definitely have a role to play.
Another round. Please be brief.
Dr. Reddy, thank you for that very encompassing briefing. As you develop this universal healthcare model, could you also look at the legal framework? Because we're not talking about drugs or products. We're talking about a service model. Service models are very vulnerable. I speak about this point from personal experience. I sit on the board of the largest company in America that does primary wellness programs around America. We went 2 years ago to India, and I do believe that there are many solutions that can form the basis of a very viable primary healthcare system in India. But the legal exposure for a foreign company at the state level is so high that no self-respecting company will get into the service model game. So please keep that in mind as you develop the solutions. I will say, on balance, the education I got through that journey on the corruption in the medical system makes me sympathetic to Mr. Menon. The percentage of drugs that are adulterated in India, the percentage of physicians that get kickbacks of 30% from the labs, the percentage of surgery that is not required in the leading hospitals. Dr. Reddy, I think we need to look at corruption.
I do not disagree with you, sir. I never disagreed with him either. I only said that corruption is not unique to India. Corruption in the medical profession is not unique to India. Even in China, it has happened now. The Chinese doctors are now practicing the worst form of medicine in terms of unnecessary procedures and so on. So it is a factor that needs to be recognized and combated. But I don't think it is something that can be attributed only as an Indian ailment. That's what I'm saying.
We'll take a few questions. And then we'll close up.
Sure.
I'm just a little confused about the essential medicines part. That seemed to be a major issue because of the relief of people falling into poverty, and I didn't quite follow the logic. So maybe you can take me through it again. If I recall what you said is that about 75% of the private sector spending goes for medicines. Is that right?
72% of the out-of-pocket expenditure.
Oh, out-of-pocket
Out-of-pocket expenditure.
Okay. And you can solve that problem by 0.1% of GDP. That's what sounds a little incredible and a little implausible.
Let me put it this way. If you want to give all the medicines in the national list of essential medicines and bring down the prices through pooled procurement, and if that were to operate both through public and private providers, it would be 0.5% of GDP. If you wanted to give it only through public facilities to begin with, it would be 0.1% of GDP.
So let me ask one other question. There is a good reason to have some payment by the public, even from very poor people, to reduce lines and reduce overconsumption. We know what happens when you drive the price to zero. You don't have to be an economist to know that demand goes to infinity. One can see in India places that are free have very, very long lines of people waiting. Waiting is not free. So you do end up trading. It's a free visit to the doctor, and you pay for it with a very long, wasted day. And so I would suggest to you that the idea that paying is always a barrier to the poor may not, in fact, be true. They've already shown you that they're willing to pay for medicine, and they're willing to pay to see the doctor. And one does have to balance the free at the point of service with those very long lines, which are not free despite the appearance of a free visit.
Well, we have had this long debate on... Okay, fine.
Yeah.
Might have to pass along.
Hi. So my question is focused on
I suspect the reason why Devesh asked you to sort of frame the discussion on can versus will. So speaking about governance and going to the point that you made about the need to decentralize some of the sort of the services and the universal health coverage at the district level, and the potential for community councils and whatnot to serve as a check potentially on the corruption that's been pointed out by a few of the questioners. I was wondering if you could speak to the potential role, if any, that the People's Health Movement could potentially play in serving in that capacity, and maybe describe, for those that may not know, what the People's Health Movement is as you answer that question.
Sure.
Dr. Reddy, initially, the metrics you pointed out versus our neighbors and other potential peers were very dismal. My question is, and to some extent you alluded to it, is it a function of the federal versus state responsibilities? Is it a function of our total expenditure on health as a percentage of GDP versus even peers that have lower per capita income and certainly much lower aggregate GDPs? Or is it a function of delivery in terms of the structure of delivery, or embedded in that to some extent leakages, as you pointed out? I mean, at a macro level, is there some couple of straightforward directions you can point to for this remarkably poor metrics that we unfortunately have faced with?
Hi, Dr. Reddy. My question is about the funding and provision of care between federal and state governments. I was just wondering if you could speak a little bit more about how you foresee those being split.
Sure. Firstly, on the issue of essential medicines, I've answered. In terms of user fee, this debate has gone on for about 2 decades now, and some of the evidence against user fee being quite detrimental to people's utilization of healthcare, even question of iron supplements, medicated mosquito bed nets, of deworming, mostly has come from Africa. But it has come from other countries too. This is well documented in the World Health Report of 2010. But in the global discourse, it has become increasingly clear that, for example, in the case of medicated bed nets, even when the price was reduced to 1%, there was no uptake. When it was reduced to 0, the uptake went up. So there are documented evidence there. Even the economists you may say very clearly that if you actually do not charge anything, people are bound to overconsume. That is a clear-cut economic argument. But what is happening is that if you charge, quite a number of people are deterred from seeking services, and that has been demonstrated in several of the countries. And even economists in the DFID have now backed off. Economists like Anne Mills from London School of Hygiene and Tropical Medicine have taken a position against user fee. Sure, but some of the primary care services too, in a poor country like where a large number of poor people in India are below the poverty line, it could still be a deterrent. What we are really saying is that we should not allow people to get frightened away from primary care, because primary care is absolutely critical. So the debate about user fee is mostly centered around secondary and tertiary care rather than about primary care. Even there are some questions. Should tertiary care be totally removed from the essential package of health services? If a young man gets a snake bite and requires a ventilator or a dialysis, do we say no? If a woman has a mishandled delivery and has a ruptured uterus or a vesicovaginal fistula, do we deny her the care? So those are questions that could be asked. But ultimately, you'll have to say no sometime. And that's where a NICE-like institution will be able to help, which are the areas where you have to say yes, which are the areas you may say maybe depending on resources, and which are the areas you have to say no. But the user fee question can be debated, but at least there seems to be a substantial body of opinion. As I said, even Jim Kim has taken a stand against it. So we'll have to look at that issue afresh. Now, in terms of the people's health movement, certainly the greater the participation of the people in terms of not only, it should be there in the entire project cycle, not only in the evaluation, but right from the design, delivery, and evaluation, the more the community's involvement, the greater the likelihood of success and the greater the likelihood of transparency and accountability. And People's Health Movement can play a role. People's Health Movement is a civil society organization with multiple component organizations affiliate. It's a network which strongly espouses people's right to health and therefore acts as their voice as well as custodian. And certainly it's globally present, but particularly strong in India. It can play a role. In terms of function of delivery, it is true that even for the money that is delivered, money that is provided, we are still not getting full utilization, nor are we getting optimal results. But that is often used as an argument saying, if governments are returning money and they're not able to fully spend the money allocated for health, why are you asking for more money? The lack of absorptive capacity is also a function of a health system weakness, which now needs to be strengthened in order to better absorb and better utilize. So that's because you don't have personnel there to deliver the services. If you don't have doctors, you don't have nurses, naturally services are not going to be rendered, money will be returned. If you have more frontline health workers, more people in primary health care, and you are supplying drugs free of cost, at least essential drugs free of cost, the money can be spent, but it requires a reconfiguration of the health system. So it is...
Labor system availability, incentive for training and people to attract to those fields, or is it a function of just the level of...
It has been a failure of our planning. But you do require both the elements to be attended to. You need more money for health and more health for the money. So you need to allocate more but also get more returns out of it. So that's required. To end on a positive note, let me tell you that in women-led panchayats, we have had a 33% reservation for local bodies, panchayats to be led by women. In women-led panchayats, a study by the National Council for Applied Economic Research has shown that spending on water, sanitation, and health is much better than in men-led panchayats.
Thank you, Dr. Ravi. Thank you, Amit, for being here. You sort of began with a bleak picture, but you ended with hope. So thank you again.
Thank you. Thank you, sir.
I will drop you a note.
Sure, sir. We'll do that. Thank you.